Hello and welcome everyone. Welcome to day 4 of the Pride Study Wrapped, our research year in review 2024. This is the final day of our 4-day storytelling through data extravaganza. I want to briefly introduce myself. My name is Daniel Moretti. I use all pronouns with positive intent, and I'm Program Management Director at PrideNet. A brief visual description of myself is that I have brown curly hair, a mustache, light brown skin. I'm wearing a white and pink paisley shirt, a lavender blazer, and hopefully the largest bow tie that you've ever seen. Just a quick note on our webinar series name. We're using the name Wrapped. It's a play on words that many streaming services are using to give you a wrapped highlight of the past year. It doesn't mean wrapped like we're done. We're here, we're queer, and we're not going anywhere. So this is a new webinar series that today is part of, and we really launched it. We wanted to create more opportunities for the Pride Study to share our research results back with the community, and also in turn to build more touch points for researchers and community members to engage with one another. Huge thanks to everyone joining us today, both folks who have joined us the previous days, as well as folks who are new today. We deeply appreciate you co-creating this community space together with us, especially in this moment. It's my pleasure to introduce our co-director for the Pride Study and PrideNet, Dr. Juno Obedin-Maliver, to provide us with brief welcome remarks.
Thank you so much. I am so honored and grateful to be here with all of you. So thank you, Daniel, and the whole team for making this possible. As Daniel mentioned, my name is Juno Obedin-Maliver. I use she and her pronouns. Excuse me. As a brief visual description, I have short brown hair, glasses, a black jacket, and a shirt with many different colors of triangles on it. And we wanted to take a moment, and from the bottom of my heart and the whole team, to thank you all so much for joining us today for the Pride Study Wrapped. We're very proud and thankful to all of our collaborators that have worked with us over the years, some of whom you've heard from over the past few days. This is the 4th day in the series of the Pride Study Wrapped sessions this week, but also all of our collaborators, participants, advisory board members, and so many other community members we work with. Since our first paper in 2019, we've published 71 papers with many more in the way, and we look forward to continuing this productivity for years to come with our ongoing and unwavering commitment to engage with and partner with LGBTQIA plus communities along the way. Our communities, especially trans and gender diverse communities, are now under specific and directed attack. And well, we need each other more than ever. So thank you for being in community with us today. Thank you all for joining us today and for your continued support, participation, dedication to making the world a better and healthier place for LGBTQIA plus people. With that, I'll turn it back to Daniel.
Thank you so much, Juno. Really appreciate those words. So the agenda for today is we are going to be first hearing about interest in over-the-counter progestin-only pill use amongst transgender, non-binary, and gender-expansive people assigned female or intersex at birth. And then we'll be hearing about the study understanding if and why transgender men and gender-diverse people assigned female or intersex at birth use birth control. Then we'll hear a double feature about health of LGBTQI plus parents, as well as how cisgender LGBTQ plus women become parents and built their families. And then we'll hear our final study about ways that transgender men and gender diverse people assigned female or intersex at birth become parents. We will then close out with some brief PrideNet updates and closing, so we hope you can stay with us till the end. Just a very brief content notice that the studies being presented today, at times, it might include sharing data that reference either experiences of trauma or discrimination. So we encourage everyone to practice self-care in the way that is most supportive for them. And before we dive in, just wanted to give some context in case you're new here, who we are. So PrideNet, we're a national network that focuses on catalyzing LGBTQIA plus health research. We really focus on doing this through connecting community members with ways to participate in trusted research, as well as, really importantly, creating opportunities for community input to inform all stages of the research process. You can learn more at the PrideNet website that Cassie posted in the chat. And the study that we're focusing on today that PrideNet provides community engagement support for is the Pride study. This is also based out of Stanford Medicine, like PrideNet. We're the first online national and long-term study that's focusing on LGBTQIA plus physical, mental, and social health. Really importantly, we're created by us and for us. Participation is really focused on an online survey once a year so we can study your health over time, and you might also be invited to participate in other ways. Eligibility is open for anyone who identifies as a sexual or gender minority, part of the LGBTQI plus community, at least 18 years old, and you can live anywhere in the US or territories, and right now focus on comfort in reading and writing in English. We're excited that we have 30,000 plus participants, but we might be missing you. If that's the case, we hope that you'll learn more in the link in the chat that Cassie has posted about the Pride study. And I wanted to also share a little bit about who are some of the voices and faces behind the Pride study, the participants, part of our PrideNet network. I'm going to play a very short 1-minute video.
I'm Alvin. I live and work in Atlanta, Georgia.
I'm Liat Feller. I'm from Stamford, Connecticut.
I am Ramon Ramirez. I'm from San Francisco.
I'm Jewel from El Paso, Texas.
I'm Donald from Chicago.
I'm Lily from Texas.
I'm Alex from Charlotte, North Carolina.
I am Nicholas and I am from Webb, Mississippi.
I'm Victor from Phoenix, Arizona.
I am Joel from Denver.
I'm Jen. I'm from Houston, Texas.
I'm Paul. I'm from Miami.
I am Rosea from Atlanta, Georgia.
And I am the Pride Study.
So huge thanks to all of you, our attendees, our Pride Study participants, PrideNet Network. Some are in the audience with us today. We appreciate you. And with that, I'm going to go ahead and invite to our virtual stage our first presenters, Kate Grindlay Kelly, as well as Jen Hastings.
Okay. Thanks, Jen, and thanks so much, Daniel. And thank you for having us on the webinar, and great to be here with you all today. My name is Kate Grindlay Kelly. I use she and her pronouns, and I'm a researcher with IBIS Reproductive Health. For a visual description of myself, I have blonde hair, white skin, and today I'm wearing a gray striped shirt. So we are really excited to share back the results of our study on interest in over-the-counter progestin-only pill use among transgender, non-binary, and gender-expansive people assigned female or intersex at birth in the United States. Next slide, please. And we'd like to start by first giving a huge thank you to the Participant Advisory Committee for the critical role that you played in shaping and improving the work. We really thank you for your careful attention and for bringing your thoughtful and invaluable perspectives. We also want to thank our amazing co-authors and the members of our study team who provided all of their support in developing the survey, who are listed here on the slide. Next slide, please. So in July 2023, the FDA approved the first ever over-the-counter birth control pill. It's called Opill, and it hit the shelves this past March. So now people of all ages and gender identities can walk into the store and buy a pack of birth control pills the same way you can get condoms or Tylenol without any prescription needed. Next slide, please. And I'll turn it to you, Jen.
Great, thank you. So I'm Jen Hastings. I'm a family medicine physician, and I've been working in the world of trans health for, gosh, now 25 plus years, and thrilled to be here and very honored to be part of this research study. For a visual description, I'm white-skinned, gray, black hair, and I'm wearing a blue jacket with a turquoise warm thing underneath. It's freezing where I am. So yeah, thank you, Kate, for starting us off. So as Kate already shared, the O-pill came out when we were doing our study. When we started our study, there was no O-pill available without a prescription. And we wanted to share a little bit more information about progestin-only pills. So this is a highly effective form of contraception, effective for people of all ages. With perfect use, it's 99% effective. With typical use, a lower efficacy, which is common with really all birth control methods. Safe for almost all people, including smokers, which is really important to have a birth control method that does not have estrogen, which is a relative contraindication for using if you are a smoker. It importantly does not interfere with testosterone. And so for those who are taking testosterone, there is not a sort of a battle inside the body about which is the predominant hormone. So it's very useful from that perspective. And studies show that people can easily self-screen to determine which birth control is right for them. And this is really an important part of our work, that people be empowered to identify what's their birth control pill. Excuse me, their birth control method. So there's things besides pills. But barriers to access, such as a need for a prescription, have historically kept birth control pills out of reach, which is clearly a health equity and reproductive justice issue. And so, let's see, I guess the next slide, please, Daniel. So, as part of our work, we developed excuse me, an over-the-counter, that's OTC, progestin-only pill fact sheet. So this is available to all of you, and it's a lot of small print, but it reviews some of the things we just talked about the characteristics of a progestin-only pill, as well as things that we'll be continuing to share with you in this presentation. So I'm not going to go over the fine points of the fact sheet, but this will be available to you. And I don't know if that's something that one of the support people could perhaps put in the chat, a link to our fact sheet. And then next slide, I'll begin to talk about our survey. So previous research that had occurred showed that both US teens and US adults, 29% and 39% respectively, at risk for unintended pregnancy who reported their sex as female were interested in over-the-counter progestin-only pills. But that the time that we started our survey, no one had ever explored or studied the interests of transgender, non-binary, and gender-expansive individuals. And we use the acronym TGE, transgender and gender-expansive individuals. So no one had ever studied this group of people. And so our survey specifically reached out to trans, non-binary, and gender-expansive persons. We did this survey before, as I already said, before the O-pill was approved, between May and September of 2019. And this study reached 1,415 individuals assigned female or intersex at birth. And they were recruited via an anonymous open online survey, as well as the PRIDE study, which is why we're here. So thank you to the PRIDE study. So next slide. So our survey was about sexual and reproductive health experiences, needs, and preferences, and included a question about interest in over-the-counter progestin-only pill. So even though this was a long time before an over-the-counter pill was introduced, we had this awareness that a progestin-only pill would be really useful to many populations. So in particular, the trans and gender-expansive population, because it was not estrogen-based. And the survey questions that we created were done in collaboration with the PRIDE study folks. So a huge thank you to all of you. This is, it was such an amazing process, and we're so grateful that we have this community relationship. So a key part of our survey was asking participants to fill for particular words related to their body parts or their experiences related to sex and fertility, like pregnancy or contraception or a body part. We asked people to share what word they would use for that particular aspect, and then we developed a system so that their responses would then autofill within the survey so that the experience of the survey was not triggering or negative. So the next slide, please, will show you a little bit about that. So if we look at our particular question about progestin-only birth control pills, instead of using the word birth control for everyone, people would choose a word that matched for them, that was non-triggering. So the question was, would you use and then it would autofill with their choice, a pill that had progestin that you could buy over the counter or without a prescription. And then we explained how the progestin-only pill worked. And so if, as you see in this slide, if someone chose a different word than ovary for their ovary, or a different word than uterus for their uterus, that would be what they would see. And we got so much positive feedback about this particular way of constructing a survey. Next slide. So Kate will tell us about what we found.
Thanks, Jen. So I'm not sure how much statistical background each of you has, but in broad strokes, what we did was calculate how many people and what proportion in our sample were interested in using an over-the-counter progestin-only pill. And we also looked at it by key background characteristics, such as gender, race, age, education, and many other background characteristics. Then to see if and how any of these were associated with interest in over-the-counter progestin-only pill use and controlling for other factors, we ran a series of regression models. Next slide, please. Respondents had an average age of 26 years old and represented numerous gender identities, sexual orientations, and race and ethnicities. More than half of participants selected more than one gender identity and more than one sexual orientation, and approximately 13% selected multiple racial and ethnic identities. Next slide, please. So overall, we found that about half of participants, 45%, were interested in using over-the-counter progestin-only pills. And in our regression analyses, we found that interest was higher among younger participants, folks with a high school degree or less, people who did not have insurance, folks who were currently using oral contraception or had ever used progestin-only pills, folks who wanted to avoid estrogen generally or specifically because they viewed it as a female or feminizing hormone, and those who had ever faced challenges with contraception coverage because of their legal gender on their health insurance. We found lower interest among people who were sterilized, had ever used testosterone for gender affirmation, and people with a graduate degree. Next slide, please. And I'll turn it back to Jen.
Thank you so much. So as compared to prior research, we had a slightly higher response in terms of people who would be interested in over-the-counter progestin-only pill. And in general, the findings suggested that people would be interested because of improved access, because they didn't have a prescription, but also because of the lack of estrogen in the progestin-only pill that we've already reviewed. So it was clear from this work that we had done that over-the-counter progestin-only pills would have the potential to improve contraceptive access. And here is the link to that fact sheet that we shared. So again, this study was done before there was an over-the-counter progestin-only pill available. And needless to say, we're thrilled that this finally moved forward and that O-pill is available. So we'll go to the next slide. And I haven't seen whether that link is has been made available to folks.
It's in the chat, yes.
Oh, good. Yay. Thank you so much for that support. So that's our data. Thank you so much. So I think, do we have time for questions, or is that later on in the time?
Yes, thank you so much. We have time for questions. And so we're going to invite folks, our attendees, please feel free to post your questions in the chat, use the Q&A function. Right now, there is some shout outs. Someone said, thank you for pointing out that an RX or office visit as a potential barrier. Many have no concept of that. So thanks so much for sharing that.
You mean no concept that that might be an that one could get birth control without having to have a medical visit or an office visit. I think that's the point. Yeah. Thank you.
Yeah, thank you so much. One question to get us started off you all are, continuing to do such impactful work. This research study, and as you mentioned, took place before the pills were available. Can you kind of talk a little bit more about like what you all are working on next, or how if this is, feeding into a larger project you all are working on, or a next project?
Yeah, thanks, Daniel. Well, now that O-pill has been rolled out, the next kind of phase of work is really focused on implementation and looking at real world access, making sure that people are able to go into store and pick it up, that it's not behind a locked, shelf, that there aren't misinterpretations of the law, which is that there is no age restriction, that it's really available for people of all ages. And then, of course, work to ensure accessibility around price and insurance coverage. So beyond research, there's a lot of advocacy and communications efforts to really get it to the broadest population possible.
Yeah, I want to emphasize the cost issue, because if something is over the counter, but it's at a price point where people just can't afford it, then it's almost as if it wasn't over the counter. So I think that's a huge advocacy issue that we're all working on.
Thank you so much. Our next question from participants is, did you get any data around potential barriers to POP for TGE participants?
We unfortunately didn't. We just had that one question on interest, and then we were able to look at these background characteristics to see what was associated with interest, but we unfortunately didn't have the space in the survey that was already very long to ask all the follow-up questions we would love to have been able to learn more about.
Yeah, we did get funded to do the study again. And so I think we're still in the process. I mean, we're early-ish or mid-ish in the process of that. So we might, again, space is a limitation with how many questions we can ask, but that might be something we dive into a little bit this time, now that it is over the counter.
Yeah.
Thanks for pointing that out. Yeah. And we are hoping to ask in that next round about actual use in addition to the question on interest.
Yeah, and thank you so much for sharing that. One thing I want to underscore is the research you all have done and are doing is groundbreaking, that there's so, like, as we get these questions from the audience, right, it just emphasizes the need for more of this research, and just gratitude for the work that you all are doing to gather this really important data. The last question that we have is, someone shared, maybe I misinterpreted, but is it true that people who had insurance or did not experience barriers to insurance or costs were less likely to use or be interested in O-pill? And then the follow-up is, if this is correct, then is there a reason that people with greater access to medication would choose a traditional birth control pill versus the O-pill?
So the finding was people who do not have insurance were more interested in over-the-counter access, which mirrors what we found in previous research, that people who didn't have insurance were more interested in in the prior nationally representative survey with people who identified as female, and kind of intuitively, makes sense that they would have greater barriers, therefore, to getting a prescription. And we also did find that people who face challenges with contraceptive coverage because of their legal gender on their health insurance, that was another area where they were more interested as well.
Well, thank you so much, everyone. Please join me in a round of applause. Light up the chat with any emoji you like, some snaps. Here at PrideNet, we throw glitter. Thank you so much, Kate, Grindlay, Kelly, Jen Hastings, for all the important research you do and being so generous and being here today to share back with the community. We appreciate all that you do.
Thank you
so much.
Thank you so much. Well, it is my pleasure to invite back to the virtual stage Dr. Juno Obedin-Maliver, who's going to be going through our next study for today.
Thank you so much. I will just again present a brief visual description for those who weren't here a few minutes ago. So my name is Juno Obedin-Maliver, and I use she and her pronouns. And I am honored to be one of the co-directors of the Pride study. I have short brown hair, white skin, glasses, blue-green eyes, a black jacket, and a shirt with some very different colored triangles on it. And I am excited to share work. Actually, many of the members, folks on this team have, who are on the presentations today have worked on this same survey, but it's coming from the survey that Kate and Jen just spoke about, and talking about understanding if and why transgender men and gender diverse people, or TGD people assigned female or intersex at birth, abbreviated AFAB, use contraception, aka birth control. And next, please. So I receive funding that was not necessarily specific to this survey, but these are some of the funding sources that I receive, as well as performing consulting work, but I don't believe that presents any professional conflicts of interest to this presentation. So next, please. I will mention three main objectives for our brief time together. One is just understand the rationale and methods of our study a bit, about TGD people assigned female at birth in the Pride study, and their experiences with and thoughts on using contraception or birth control, and understand some of the results from this study about contraceptive use and reasons for use and non-use of birth control among TGD individuals, and appreciate the context in which the study was undertaken and some next steps. A few notes on language. You've already heard me do it, but I'll just say will use sort of TGD without sometimes the assigned female or intersex at birth going forward, since that was everybody in the study that I'm talking about. And in our study, we've evolved language, and different papers talk about TGD or TGE. And so you'll hear that a little bit. It is different from what Jen and Kate just presented. And I'll be using the terms contraception and birth control interchangeably. Okay, next slide, please. So the big question is, why study birth control or contraception? And the real underlying principle here is that people with a uterus can and do get pregnant, and some would like to prevent those pregnancies. And a tool to help with that is contraception or birth control. And the definition of that, according to the National Institutes of Health, is the use of drugs, devices, or surgery to prevent pregnancy. And there's many different types of contraception or methods, also called birth control. The kind of modern era of birth control has shifted, but since the 1950s, we've been using sort of more or less many of the methods that we're using today. And in 2022, over 880 million people with pregnancy prevention potential used birth control, which is about 78% of folks of reproductive age. And so equitable access to the full range of contraceptive methods for all those seeking care is an essential component of high quality sexual and reproductive health care. And I would just say as a component of healthcare and well-being. And the Centers for Disease Disease Control and Prevention has mentioned that recently. But despite that, little is known about contraceptive needs and experiences specifically for pregnancy prevention among transgender and gender diverse people, because you can actually use contraception and birth control for other reasons, which we won't talk as much about here today, but you'll see people mentioned a few of those. So next slide. And underscoring the why of this research is also that, all prior, even though something like 78% of people with pregnancy potential around the world use some form of birth control or contraception at some point in their lives, the research that has underscored a lot of that medical care and clinical care is really inaccurate in a lot of the assumptions that it makes. And so we just have two examples here of two big studies that sort of help set a lot of the clinical care that we undertake in this country, as well as research. And you can see that they make a lot of assumptions. So the first one, and what about your partner at the time you became pregnant? Did he want you to have another baby at some time? So lots of challenges here in terms of, presuming that the partner is he, and also about agency and other questions. There's also the next quote, which is just one more example among many. Did you or your partner do anything the last time you had sex to keep you from getting pregnant? And in this one, you can see there's assumptions about what does sex mean here. It presumes that sex is always, or always means penis and vagina sex, where sperm is released in or near the vagina and could result in pregnancy. And that's not all the types of sex that there are. So with those inaccuracies, we wanted to do better. Next slide, please. And so starting in 2017, an interdisciplinary group of researchers, clinicians, advocates, one of whom is also just presented today, Jen, but many, many others came together to address the bias that we were seeing in this existing research and approaches on sexual and reproductive health. There are more people that I can name, but lots of hearts and shout outs to them. And we decided to design a research study to better include people of diverse genders and experiences, and without heteronormative assumptions or assumptions about what types of sex and behavior people were engaging in, and to get as specific and accurate as we could. And we've since published 14 papers on this work, given many presentations, and as my colleagues Jen and Kate mentioned, we're planning to review this and launch another study in the current era. Okay, and you can see research from those other papers at pridestudy.org/research. Okay, next slide, please. So turning to this particular study at hand, which is Pride Study manuscript number 65, and was titled here, Contraceptive Use Among Transgender Men and Gender Diverse Individuals in the US, Reasons for Use, Non-Use, and Methods. We really had two main questions, which was to understand whether and how transgender and gender diverse people use contraception specifically for the goal of not getting pregnant or pregnancy prevention, and to understand how the use of birth control is different or not among TGD people who are also using testosterone. This was a collaboration, many people, including those from IBIS Reproductive Health, and you can check them out as well. Next slide, please. So we recruited via two platforms from the Pride Study, which hopefully you all know a lot about now, and our website, but also through an anonymous website in case people didn't want to be involved in a long-term cohort. And that novel questionnaire was launched in 2019, and that questionnaire has a lot of great methodological details and other things, and you can see that questionnaire as well as the programming language, et cetera, that we used is also available on our website. But now we'll talk about results. Next slide. So in terms of, some our big questions, I wanted to focus on age. So we had 1,694 transgender and gender diverse people who were assigned female or intersex at birth who were eligible for this analysis. So it's a little different. You'll see different numbers, even though it came from the same base study. The median age was 27, and that puts us squarely in sort of what a lot of researchers and healthcare providers think of as reproductive age, which most people think goes up to about 45. And about 72% had ever used testosterone, and 20% were currently using it. And we noted that testosterone use differed by gender identity, which is also really important as we think about who needs what care and what people may already have in their bodies and how it influences other healthcare decisions that they make and healthcare that they need. Next slide. So when we looked at reasons for using contraception and non-using contraception, 71 people had ever used some form of contraceptive method, and the most common reasons for use were pregnancy prevention, about half of folks, avoiding period symptoms and stopping getting a period, and avoiding getting an STI. Reminder, internal and external condoms are really good methods of helping prevent transmission of STIs, and that's also a contraceptive method. Reasons for not using, not having penis and vagina sex or sex with sperm involved, and not wanting to use estrogen or other quote unquote feminizing hormones. Next slide, please. So the methods little technical glitch. Methods of birth control that people had ever used in the most common forms were external condoms, combined hormonal pills, withdrawal, or abstinence, or not having sex with sperm involved. And the current contraceptive use methods that people used that were most common were a little different. Condoms were the same, but hormone IUD as well as also came into play. And then if we think about differences by never or ever testosterone use, meaning people who were also using testosterone, did it influence their current contraceptive use compared to people who were never using testosterone? And there were a few differences in terms of what people were using. So condoms was more likely, and combined hormonal contraceptive pills were less likely if you were on testosterone, and fertility awareness methods were also less likely. Okay, now we often get questions, sorry, next slide. We often get questions about whether testosterone is used by folks as a contraceptive method, and can we actually think about it as a contraceptive method? The short answer is we shouldn't yet be thinking about that. We don't really understand how good it is at preventing pregnancy, but some people do rely on it as birth control. That's not what we recommend as healthcare providers, but we know that some folks are doing that, and about 4% had ever done that in our study, and 7% in the, 4% were currently doing it and 7% in the past. And most were not using other methods as well. So just to zoom out, we'll go to the next slide for a second and talk about these results in context. This was a very descriptive new study that helped us focus on birth control use for pregnancy prevention among transgender and gender diverse people assigned female and intersex at birth. In 2019, when we did the survey, 50% had used contraception for pregnancy prevention. It just underscores and challenges assumptions that this might not be, say, relevant to trans and gender diverse people, but it certainly is. And the two most common forms that were used by people of contraception were high autonomy methods, meaning they don't require medical interactions, so condoms and withdrawal. And so I think that, to me, says that, it's important and counseling to really think about how we can meet people where they're at and give them power and autonomy, as well as counseling on other methods. But This survey was done in 2019. A lot has shifted in the world. I don't have to tell you that just recently in the last few weeks, but especially in the past couple of years. And we're in a place where a lot of the shifts are creating more what we call our contraceptive deserts. And what that means is living in a place where people lack reasonable access to a healthcare center or providers that offer a full range of contraceptive methods. And that's over 19 million people in the US. And if you look at this map, which shows contraceptive deserts, which are sort of in the light, tan colors or red colors, those are expanding and they often map onto the same places that restrict gender-affirming care or access to gender-affirming care. And many places that are provisions of sexual and reproductive health care and contraceptive care also provide, for example, gender-affirming hormones and care and vice versa. And so this is really, we should think about this together as a mutual fight and opportunity. So in my conclusions, next slide will say that, contraception or birth control is needed and used by trans and gender diverse people. And actually all methods were used, and therefore patient-centered counseling matters. And there's a lot more of that in the paper. And testosterone use, how testosterone use influences contraceptive needs and the efficacy of other methods, and is really an active area of study. We need so much more data on this and more research. And that advocating for gender-affirming care includes contraceptive access and vice versa. They're intertwined as part of the fight for bodily autonomy and reproductive justice. So next slide, and thank you so very much for your kind attention.
Thank you so much, Dr. Juno Obedin-Maliver. Just really appreciate you sharing this research. I want to, again, invite our attendees, if you want to ask a question, you can feel free to type it in the Q&A function, or you can also put in the chat. I'm going to go ahead and read. This is more of a reflection. Reflections are welcomed as well. So someone says, having done some exploratory HIV prevention work with trans men and trans masculine non-binary folks, I can say that pregnancy prevention is really what is at front of mind for folks more than a lot of other things. So this research is so, in all caps, welcomed to see.
Well, thank you for that comment. It's such a great point. I think we don't live just in certain topics or silos in our bodies, and so we are whole people, and our research and our healthcare need to think about all of our healthcare needs and opportunities to support people living their full lives.
Yeah, thank you so much for sharing that reflection. One question, was there anything in the course of this research, any phase of it, that either stood out to you as surprising or was a moment where it was kind of a aha or a light bulb moment?
So many that we're doing more research, actually. That's a researcher's answers to that, but so many good questions. I think just really continuing to see, it wasn't surprising, but really heartening to see, people don't fit neatly into boxes. And I actually think that's a beautiful thing. Our assumptions about what people, in interacting with a method, a contraceptive method, what people wanted to use. People used things across the board. So just because somebody is taking testosterone doesn't mean, for example, that they don't want a birth control pill or they don't want, an IUD. There were differences when we look at the population level, but that doesn't necessarily say, for any one individual. And so, research is really helpful thinking big population-wise. Something that always comes through, and we got a lot of qualitative comments from participants, was how much they appreciated being seen as individuals, and that was really helped by them being able to, for example, use their own language in the survey that Jen and Kate talked about in the prior lecture. So that was something that just continues to charge us forward, is how to both represent big populations and also really understand everybody's unique stories.
Thank you for sharing that. I love the way that you framed it in terms of not fitting neatly into a single check box is what's so beautiful about our communities and our lived experiences. So Thank you so much for sharing that.
Great.
Great. Well, everyone, oh, did you have any final remarks you wanted to share with
No. Welcome questions, and all of the papers are available, so please feel free. Thank you all.
Fantastic. Well, please join me in a round of applause, some snaps, and throwing lots of glitter to Dr. Juno Obedin-Maliver for all of the work that you're doing and for being here to share back the findings. And feel free, if folks have additional questions on this study, feel free to add them to the chat or the Q&A. So it is my pleasure to welcome back to the virtual stage. If you joined us yesterday, you'll see a familiar face. It is Dr. Diana Tordoff, who is going to give us another double feature of research, but then we'll pause and have Q&A for both studies.
Well, welcome everyone. Thanks for joining today. My name is Diana Tordoff. I use she, her pronouns. For a brief visual description of myself, I have long brown hair, light skin, and I'm wearing a black sweater. I'm currently an instructor in the Department of Obstetrics and Gynecology at Stanford, and I also recently completed a postdoctoral fellowship with the PRIDE study. And so today I'll be presenting two studies about LGBTQ plus parenthood. And relevant to my talk today, I am a queer cis woman and also a new parent to an adorable 6-month-old. And so much of the research presented here is particularly special to me, as it happened while I was planning how to build my own family, as well as while I was pregnant. And so the first of these studies looks at the health of LGBTQIA plus people who are parents. All right. So for this study, we are interested in understanding how parenthood impacts health. And this includes mental health, physical health, as well as health behaviors. And so we compared the physical and mental health outcomes of LGBTQIA people who were parents to those who are not parents. And it's important for understanding the health of LGBTQ plus parents for several reasons. The first is that around a third of LGBTQ adults are parents, which is equivalent to at least 3 million people in the United States. In addition, there's currently a generational shift in LGBTQ family building. So younger generations are both increasingly likely to identify as LGBTQ plus, and in addition, younger generations are more likely to desire becoming a parent or having children than prior generations. And so overall, this means that we anticipate that there's going to be more LGBTQ plus people building their families. So for example, a recent survey that was conducted by Family Equality found that 63% of LGBTQ people aged 18 to 35 are considering expanding their families either as first-time parents or by having more children. So in the PRIDE study, we found that overall 15% of participants were parents, and that this differed by both gender identity and age. So we found that women were most likely to be parents, 41% of trans women and 18% of cis women. And we also saw that the likelihood of being a parent increased by age. So 2% of those in their 20s reported being a parent. 18% of people in their 30s reported being a parent. And 38% of people aged 40 and older reported being parents. So first, looking at our results for mental health outcomes. When it comes to mental health, we found that compared to LGBTQ people who were not parents, parents reported worse mental health outcomes. This included worse depressive symptoms, anxiety symptoms, as well as PTSD symptoms. We also saw that there was a large difference in mental health diagnoses and symptoms by age. So among parents, we saw that mental health was worse among younger LGBTQ parents. And so this chart shows how common each of these outcomes were, with the youngest parents aged 21 to 29 shown in pink, and the oldest parents aged 60 plus in blue. So along the bottom, we saw that younger parents were more likely to have ever had a depression diagnosis, an anxiety diagnosis, or a PTSD diagnosis. And we also saw that they were more likely to report moderate to severe depressive anxiety and PTSD symptoms in the last 2 weeks. Looking at physical health and health behaviors, we found that there was no association between being a parent and having an increased likelihood of diabetes, of living with HIV, having high blood pressure, alcohol use, or substance use. However, we did find that parents are more likely to have ever smoked cigarettes and to be diagnosed with pelvic inflammatory disease. So what does this mean for our communities? We found that parents experienced poor mental health more frequently than non-parents. And importantly, this finding is similar to what other studies have seen among heterosexual and cisgender parents, and is generally attributed to the increased stress and financial burden of raising kids. However, we know that LGBTQ parents are more likely to encounter inequities and discrimination through family building, as well as the experiences of parenthood and raising children. So, for example, LGBTQ people are more likely to adopt, foster, and undergo medically assisted reproduction, such as in vitro fertilization, and are also more likely to encounter discrimination through these processes. For example, poor treatment of the non-pregnant or non-gestational parents in these processes. Additionally, internalized homophobia, receiving less support from their families, and the lack of laws that protect and support LGBTQ parents have strong associations with increased symptoms of anxiety and depression among new parents. So looking ahead, we know that future research needs to identify ways for healthcare and other social organizations and services to support diverse LGBTQ parents and families. So we're currently looking at how individual, interpersonal, and community level factors impact the mental health of LGBTQ parents. So I was recently invited to give a podcast interview for this paper by EpiTalk, which is the podcast associated with the journal's Annal of Epidemiology. So if you're interested in listening to this interview, you're welcome to scan the QR code. And then the link to the full paper should be provided in the chat. All right. So up next, I'll talk about a second paper, which is how cisgender LGBTQ women became parents and built their families. And here you'll hear me use the term LGBTQ plus as well as sexual minority interchangeably. So in this study, we asked sexual minority cisgender women about what methods they used to become parents, as well as their experiences of pregnancy. So for participants who had been pregnant, we also asked them to share the outcomes of each of their pregnancies, for example, including live birth, miscarriage, or abortion. So why is this important? First is that an estimated 10 to 20% of cisgender women age 18 to 40 are LGBTQ plus. And also it's important because we included all cisgender women who self-identified as LGBTQ plus. And many of the previous studies about family building or how LGBTQ plus people have built their families have really been limited to cisgender women who are in same-sex couples. And importantly, this excludes a large portion of the community, such as cisgender LGBTQ women who are single parents, as well as those who are in partnerships with transgender men and cisgender men. All right, so first we'll look at the methods cisgender women use to become parents. We found that most, 74%, used pregnancy to become parents. However, we also saw that 14% were step parents, 10% used second parent adoption of their child that their partner carried, 10% used adoption, and 4% used fostering. We found that few participants use reciprocal IVF, which is when one partner uses in vitro fertilization to carry the egg provided by another partner. We also saw that few participants had worked with an egg donor, and no participants reported using gestational surrogacy. Notably, these are among the more costly methods for family building, and the fact that so few folks reported using these methods suggests that there may be financial barriers to accessing these methods of having children. We also saw that approximately a quarter of LGBTQ cisgender women used donor sperm to conceive their children, and we found that anonymous donor sperm was significantly more common than using known donor sperm. And importantly, among LGBTQ plus cis women who were parents, only 28% reported that all of their healthcare providers were aware of their sexual orientation. There are also notable differences in the methods cis women use to build their families by sexual orientation. So here we're showing bisexual women in pink, lesbian women in orange, pansexual women in green, and queer women in blue. And along the bottom of the chart, we list different methods that people use to become parents. So for example, we saw that bisexual and pansexual women were more likely to use sexual activity with a partner to become parents at 61 and 62%. And lesbian women were least likely to use sexual activity at 31%. We also saw that lesbian and queer women were the only ones who reported reciprocal IVF to conceive their children. And lastly, lesbian and queer women were also most likely to use donor sperm, second parent adoption, or traditional adoption. All right, next we asked about people's experiences with pregnancy. So as a reminder, LGBTQ plus cisgender women mostly used pregnancy to build their families, but not all cisgender women use pregnancy to become parents. So when we looked overall, we found that 19% of cisgender LGBTQ plus women had ever been pregnant. And we saw that around a quarter desired to become pregnant at some point in the future. And among those who desired a future pregnancy, around half of them desired pregnancy within the next 5 years. And notably, we saw no differences in desire for pregnancy, future pregnancy by sexual orientation. Among people who reported being pregnant, we asked them to report the outcomes of all of the pregnancies they had. So among 558 pregnancies, most of them, 59%, resulted in live birth, 23% ended in miscarriage, 15% ended in abortion, and 2% were ectopic pregnancies that occurred outside the uterus and could no longer continue. And so importantly, among LGBTQ cis women who had ever been pregnant, we saw that fewer, 23%, reported that all of their providers were aware of their sexual orientation. All right, so what does this mean for our communities? So we know that LGBTQ plus women's reproductive healthcare experiences include discrimination and feeling like their identities and experiences are invisible due to assumptions that they are heterosexual and lack of LGBTQ plus competency. Therefore, it's important for healthcare providers to be familiar with the variety of methods that cisgender women use for family building in order to better support them. So where are we going with this research in the future? We plan to study the experiences of LGBTQ plus cisgender women, as well as their partners as they try to become pregnant, with the overall goal of better understanding barriers to accessing care and how to improve their physical and mental health of their parents, as well as their children. All right, so if you would like to read the full study, you're welcome to follow this QR code, or you're welcome to follow the link in the chat.
Fantastic. Well, thank you so much for presenting both of those studies, Dr. Tordoff. Lots of love in the chat. Someone shared, as a fellow new LGBTQ plus parent, thank you so much for this research. I'm going to go ahead and jump into the questions. So the first is, why do you think the number of trans women who are parents is so high compared to other groups slash cis heterosexuals? This was from the first study about health of LGBTQI plus parents.
Thank you. I think that because trans women in the Pride study are a slightly different demographic, meaning that they're older. And so you saw that when we looked by age, around 38 to 40% of those age 40 and older were parents. And I think this is just like a classic confounding by age, that a lot of the trans women in our study tend to be on the older side.
Thank you so much for that context.
Yeah.
The next question is, can you help to define what an anonymous donor is and what a known donor is? What if you use a bank and are given some access to the donor's information? Is that still anonymous?
Thank you for that question. So typically, the term anonymous donor refers to folks who you don't know personally. So if you use a sperm bank, and you are using the sperm of someone who provided or donated sperm through the sperm bank that you don't know personally, that's considered an anonymous donor. Sometimes if you have an anonymous donor, there are rules about contact at age 18, et cetera, and those can really vary by both bank and individual. The term known donor refers more specifically to people choosing someone in their lives who they know to provide sperm. And so this can happen either through going through a sperm bank, and this is called direct donation, or it can occur not through a sperm bank, sort of just in folks' own home. These can include sometimes folks use sibling sperm, sometimes folks use sperm of people who are good friends, or just, other queer people in community who are excited to help people build their families kind of in a cheap way outside of these, medical institutions.
Thank you so much for providing that context. The next question is, do you know if miscarriage rates are higher for sexual minority women?
That's a great question. There is very little data, and so that's not something we could specifically look at in our study. But we do know that sexual minority women do experience a number of reproductive health disparities. And so a lot of really wonderful work led by Dr. Juno Obedin-Maliver have found that sexual minority women do experience some disparities in pregnancy-related outcomes. And so I think the hypothesis is yes, but we don't really have very good data to demonstrate that at this point.
Thank you so much. And again, kind of pointing to the need for, ongoing future research on this really important area. The next question is, this is around the second study. I know that stats can sometimes be misleading. Is your reference of 23% of women telling their providers their sexual orientation low? Did participants say why that was? Did they choose not to come out? They're just curious to know more about that.
That's a great question. So those data points were collected for folks who are familiar with some like nerdy LGBTQ measurements. That was a question modified from the Nebraska Outness Score, which asked people what percent of your healthcare providers do you feel like are aware of your sexual orientation? And they were provided with 0% options up to 100% options. And so we really didn't ask questions about reasons why they felt that their providers weren't aware of their orientation. And so I think that's a really great area for future research. I know that a lot of these institutions don't directly ask about sexual orientation or just make assumptions, and that that really contributes to a lot of queer women feeling invisible in those spaces.
Thanks so much for sharing that. Second to last question is, someone says, thank you for your incredible work, Dr. Tordoff and team. I wanted to ask whether you found any physical or mental health differences / disparities among LGBTQ parents of color.
Thank you for that question. So for this analysis, we did not look at intersectional differences by race and ethnicity, but that's certainly something that we can do in the future.
Thank you so much. Again, pointing to this being an area of groundbreaking research, and it's surfacing up, more and more research to be done. So appreciate everyone that's been on this presentation and Dr. Tordoff's work in this area. So the last question, this is for the second study someone shared. I love all this information. Can you review the slide again about ways that LGBTQ plus cisgender women become pregnant? Was the most common method not through a clinic?
So we, in this survey, we did not specifically ask about participants whether they used fertility services to become pregnant. And this, so we found that the majority of folks used sexual activity with a partner to become pregnant. And this is because we included folks who self-identify as LGBTQ, and we're not necessarily restricting to same-sex couples. So this reflects the fact that individuals could be bisexual and have a cisgender male partner. This can reflect cis women who are in a partnership with a trans woman and they feel comfortable using sexual activity to achieve pregnancy. This can also reflect that folks became pregnant earlier in their lives prior to coming out and use sexual activity, and then came out later in life once they're a parent. And I think this really underscores why it's important to not just focus on same-sex couples, but to really focus on, the breadth and of the LGBTQ community to better understand how we build our families.
Fantastic. Well, huge thanks everyone for all of your great questions. Please join me in a round of applause and our snaps and throwing glitter to Dr. Diana Tordoff for all of your really, really important research and for being with us 2 days in a row for the Pride Study Wrapped. We appreciate you.
Thank you, Daniel.
All right, well, it is my pleasure to welcome to the virtual stage our final presenter for today, Shalmali Bane, who is going to talk more about their study. I'll go ahead and hand it over to you.
Great. Thank you, Daniel. And thank you everyone for being here today. My name is Shalmali Bane. I am currently a postdoctoral researcher with Kaiser Permanente Northern California's Division of Research. But I completed my PhD in epidemiology last year at Stanford School of Medicine, where I had the opportunity to work with the Pride study. My pronouns are she and her, and a quick visual description of me. I have short brown curly hair, light brown skin, I'm wearing glasses, and I'm wearing a black sweater. And today I would like to present on our study looking at how transgender men and gender diverse people, I'll use the acronym TMGD in later slides, who were assigned female or intersex at birth, became parents in the United States. If some of this sounds familiar, this is the study is somewhat of in a fitting metaphor, a sibling study to Dr. Tordoff's research that we just heard about. So using a similar sample, or using a similar question, set of questions, we analyzed the T part of the LGBTQ spectrum, asking how transgender men and gender diverse individuals instead became parents. Next slide, please. Briefly, I'll walk folks through the background and motivation for this study, our methods that people have already shared on extensively today, so maybe we can run through those quickly, and then some key findings and next steps. And I'm sure the link is already in the chat or will show up briefly to access the main study that's published, was published last year. Next slide, please. So as background, and this is not new information to folks on the call, transgender men and gender diverse individuals who choose to give birth have unique birthing experiences and also tend to face substantial political, healthcare-based, and socioeconomic barriers. And we also know that the same population builds their families in ways aside from parenthood and aside from pregnancy. Existing evidence, and main motivation for doing this study is that the existing evidence is largely qualitative and mixed method studies. So we were fortunate to build on the back of that amazing research. But this study was a unique contribution because a lot of that research is ex-US from Europe predominantly and tends to be smaller samples. And our overall goal here, as with a lot of this research, is to really support the creation of evidence-based and culturally competent reproductive healthcare guidelines and to facilitate that kind of healthcare. Next slide, please. So for this study, we used participants, or we used data from participants who were enrolled in the PRIDE study, as well as from the general public via a general public facing website from May to September of 2019, and selected the individuals who identified as transgender men or gender diverse individuals assigned female or intersex at birth, and this was about 1,700 individuals. And then for the purposes of this study, we further explored categorizing these groups into three broad buckets. First, individuals who only endorsed either man or transgender man as their gender identity. We looked at 966 individuals who only endorsed anything among the list of gender diverse identities. And then we looked at the 232 individuals who endorsed both of the above buckets. So they endorsed both either man or transgender man and any of the gender diverse identities. And this sort of reflects that in the original survey that we fielded, the gender identity question was a checkbox. And so folks could select multiple. And so this was sort of our attempt to kind of understand some patterns and trends. So then among these participants, we looked at sort of three buckets of questions. One, we asked how they became parents. Two, among those who were pregnant at any point in the past or currently pregnant, we asked what the outcomes of their pregnancies were. And then we also looked at the type of counseling related to fertility or reproduction that was received prior to gender-affirming hormone therapy among the subset who had initiated gender-affirming hormone therapy. Next slide, please. So a total of 200 participants in this sample were parents, and they used a variety of methods to build their families. 36% carried a pregnancy having provided the egg. 26% were step parents, 14% were adoptive parents, and 6% were foster parents, and then they were smaller proportions of the other categories. And then splitting this up by the different buckets that we looked at, we saw that these proportions did tend to vary, but there were small samples kind of when you split into these groups. Next slide, please. And then there were a total of 433 pregnancies in our sample. Among this whole group, we saw there were about 40% that resulted in live birth, 33% that resulted in miscarriage, 23% that were C-sections, and 22% that were abortions. Comparing this to population level data, the rates for C-section align with about what we would expect, with some sort of differences for these other birth outcomes. And then we had sort of smaller proportions that resulted in ectopic pregnancy, stillbirth, and then a few participants who were still pregnant at the time the survey was fielded. Could we move on to the next slide, please? And then this was sort of a pivot from our original question, but we saw some interesting and compelling data and wanted to explore it further. So looking at the subset of participants who had initiated gender-affirming hormone therapy, or in this case, testosterone use, we wanted to understand when they received fertility counseling from their clinician or provider relative to the timing of starting T. And so, surprisingly, about 32% of participants wrote down or selected that they received this counseling after initiating hormone therapy, and about 70% received counseling before. And then we kind of split up the groups of individuals who had received this counseling before, asking them the nature of that counseling and what kind of advice they received. And these percentages don't add up to 100% because participants could select multiple fields. So about 50% were told that they would be able to get pregnant after starting testosterone. 9% were told the opposite, that they would not be able to get pregnant after starting testosterone. 40% were informed that the provider was unsure of their ability to get pregnant. And then 46% were advised to investigate fertility preservation options before starting hormone therapy. And just as an overarching point, about 11% of the overall sample of about 1,700 participants stated that they desired a future pregnancy. So in that case, that's a subset. It's a high proportion we would expect uniform recommendation to receive fertility counseling prior to initiating hormone therapy. And then about 70% of those individuals had previous or current testosterone use. Next slide, please. And then sort of part of this exploratory analysis, we noticed that in the previous checkbox question where participants were asked about what type of counseling they received, there was an open field response. And we noticed that about 70 participants took the opportunity to write in and provide more context on the fertility counseling that they received before or after initiating gender-affirming hormone therapy. And so we conducted a rapid analysis of these open responses. We didn't want to leave this data unanalyzed or unshared. And we present a range of the quotes in our published study, but I wanted to present a few today. One, to highlight sort of the contradiction that some individuals were informed that they would not be able to get pregnant, and that, as one participant said, that probability would approach 0 over time. Some were informed that testosterone is not recommended as a form of birth control, as Dr. Obedin-Maliver shared during their presentation. And then sort of a range of information on that pregnancy could be painful to carry to term on hormone use, that participants didn't need to worry about being on birth control while on hormones, and then providers sharing their own sort of uncertainty around where the research stands with testosterone and fertility. Next slide, please. So to summarize, I think the biggest contribution, I think, from this study is first to provide evidence that transgender men and gender diverse individuals are successful in building their families, whether it's through pregnancy or a myriad of other options available to them. However, we also highlight the gaps in the healthcare that they receive, and that there's a need for additional transgender specific research and patient resources on pregnancy after testosterone therapy, as well as education for clinicians on how to counsel patients with regard to their reproductive and fertility desires. And that really this counseling should be consistent and evidence-based. And as we saw in this small sliver of data, at least, there is evidence that this counseling is not consistent. In terms of next steps, there is a update planned of these data collected in 2019, which feels like a lifetime ago at this point. So definitely looking forward to seeing how more contemporary data will reflect family building practices among this population, as well as ongoing dissemination efforts of these findings. The one caveat that I should mention in the data that we see with regards to how these populations build their families is to say that this is what we observe. And so I personally have, in writing the paper, been careful to interpret whether this is what is preferred among these populations or just what they are doing with the choices made available to them. And so putting that asterisk on, more qualitative work is needed to be done to understand what these populations want versus what they're leveraging in what's available to them based on cost, preference, and the sociopolitical environment. And I think that can bring us to our next and final slide. So yeah, that's what I have to present today. I'm happy to talk further, answer questions. That's my current email address. And just wanted to thank folks on the call as well as folks on the panel. This was absolutely a crucial part of my PhD training, was conducting this research, and I think so informative as someone who wants to continue to study reproductive and pregnant populations, to do that from a place of understanding everyone who is affected.
Thank you so much for sharing this really, really important research. And we're seeing lots of heart emojis, clapping emojis, lots of appreciation for what you shared. I'm going to again invite folks, if you have any questions, you can write into the Q&A function or type into the chat. I'm going to go ahead and just to get us started off, I really love to hear, the connections across the different studies that are being presented today and the teamwork that's being done. As you're kind of sharing, this was part of your, PhD process. Would you mind just sharing a little bit about what that process looked like in terms of the collaboration and the mentorship, what that experience was like for you?
Yeah, thank you for that question. And this, I think, is just a demonstration of how great the PRIDE study is and how it's set up. This was something that I really wanted to investigate as part of my doctoral training. My dissertation was looking at pregnancy outcomes among racially and socioeconomically minoritized populations, and I'm interested in social disparities as someone who falls into several of these buckets, as someone who is of South Asian descent and is also a queer individual. And so it was just a testament to the mentorship that this group offers, that I was able to reach out to both Dr. Obedin-Maliver and Dr. Moseson, who I think may be on the call or may have to step out, that I reached out to them with this interest, and they were able to get me started and use my sort of labor and my interest, and it was a win-win situation. And so I really appreciate that, and I think that I almost feel like this is a disservice that more programs don't have this sort of rotational setup, because this has forever changed how I investigate my population. And I consider populations in my future study, and I know that Kaiser is working towards collecting better data. We do not have good data currently, and this work has given me kind of the grounding to feel confident to pull up a seat at the table and demand better.
Well, thank you so much. And just, the appreciation that you shared of, working with PrideNet and Pride Study, it's equally mirrored the inspiring energy and motivation that you and many others that are leading this research just deeply appreciate it. We see that appreciation is resonating amongst the audience here as well. So please, everyone, join me in giving a big round of applause, some snaps, and throwing lots of glitter. Thank you so much, Shalmali, Bane, for all that you do and for being here in space and sharing back with us today. We're going to invite you as well to stay connected with Pride Study. You can follow us on social media. We're on Instagram, Facebook, X at the Pride Study. You can also connect with us through email, pridenetconnect@stanford.edu. My colleague Cassie is also going to type into the chat the link to sign up for the PrideNet newsletter. The newsletter is really our go-to source for everything that's happening with PrideNet. So you'll learn about webinars such as today, online events, resources, in-person events. So if you want to stay connected, definitely please find us on social media, sign up for our newsletter. And in closing, we invite everyone to join us. If you're a researcher and you're interested in, having a research collaboration, maybe, being back here in a year's time to share out the research that you've done with Pride study data. There's the link in the chat and the QR code on the left where you can learn more about the process for researcher collaborations, the different steps and opportunities. And also, if you're interested in becoming a participant, if you aren't already, we invite you to learn more about the Pride study. There's a link in the chat where you can register and also our website to learn more. And you can also scan the QR code on the right. But most of all, wanted to say thanks to all of our presenters today. Huge thanks to all of the PrideNet team in the back end making today flow through the day. And huge thanks to everyone here for sharing space with us, for being a participant, for being part of this community space we've co-created. We appreciate you all. Take good care and have a great rest of your day.